What an amazing thing our immune system is. We've seen how we have nonspecific and specific immunity and just how well they do their job. What we're going to talk about in this next section, though, is that sometimes that immune system can actually not be serving us as well as it should, or it can be over serving us. And in other words, it can actually be so powerful in when it's attacking disease that it's causing injury to our own cells. So this next section is dealing with, in chapter 14, dealing with immunopathology. And then we're also going to look at those student learning objectives from chapter 15, which is diagnosing infections. So let's go ahead and get started. What we understand is that in immunopathology, this is actually looking at this idea that it can actually be overreactive or underreactive. So hypersensitivities can be harmful in localized regions, but also in systemically in our systems. And then if we don't have enough of an immune response, we can have deficiencies which set us up for opportunistic infections and diseases. So we'll go ahead and move through this. As far as the hypersensitivity states go, there are 4 different types, and when we look at those 4 different categories of hypersensitivity, you see that this first one is mostly dealing with IgE category of immunoglobulins. We remember the different classes. IgE is going to be involving just typical things like hay fever, asthma, and it can be as serious as anaphylaxis, which is going to be a systemic shock situation. So you should understand that in this type 1, the immediate, there's 3 different categories. Hay fever, which is kind of localized. You can have other localized allergies. Asthma, which we know each asthmatic event is a life-threatening event, and asthma is due to a hyperreactive allergy situation that affects the respiratory system, and again, each event can be a life-threatening event. And then we can have systemic anaphylaxis, which can also be obviously a very serious type of thing. So looking at some of these hypersensitivities, you see type 1 here with the several things we just talked about. Type 2, and again we can go back to our list, but type 2 is going to be antibody mediated. So when we think about type 2, we understand our antibodies are wonderful things that we make, but they're going to attack specific antigens. So if, for example, a patient's getting a transfusion and you present to them a foreign antigen and a blood product that they have an antibody to, then their own antibodies will attack that foreign antigen and cause sometimes absolutely life-threatening situations. So the third type of hypersensitivity is an immune complex mediated problem, and in this situation you have antibodies that you've made because you actually have encountered certain diseases that are foreign antigens to your system, and you've made appropriate antibodies to those particular situations, but then all of a sudden, because of the antibody overstimulation, damage can be done to basement membranes of those target organs. So some examples to this are going to be the autoimmune diseases that we think about, like with systemic lupus, that is going to be of connective tissues, rheumatoid arthritis, rheumatic fever. So underlying organs can be damaged because of that hyper reaction to a basic infection. And some of the things that can happen, another example that you may have heard of in anatomy and physiology, is something called acute glomerular nephritis. Acute glomerular nephritis is when because of a strep infection that you have, a sore throat that you will get over, even without treatment, you would get over within a week or so. But because of that streptococcal throat infection, your immune system responds in such a way that in rare cases you have patients that will come in and their kidneys have failed. Their kidneys have shut down, and sometimes the kidney damage is permanent, so those people are going to have to go on transplant list and wait for kidney transplant and have to have full-time dialysis until they get there. So the reason we treat people who have pharyngitis, just a sore throat with Streptococcus pyogenes as the cause of that, is so that we can prevent this overreaction of the immune system, because we know that when we give antibiotics, it actually, while it's fighting against the antibiotics, fighting against the bacteria, it is also at the same time suppressing our immune system. So this is why we're very, very careful that we don't give antibiotics unless we know what we're doing, because if you're not giving the right ones, then the only thing that you're doing is harming the immune system. So good. We get that there can be either a hypersensitivity, or there can be a hyposensitivity. So we're talking about the hyper ones right now at this time. Type 4. The type 4 hypersensitivity is typically going to be because of sometimes delayed reactions, because there may be a molecule, they're called haptens, that if you have molecules that can join with them, if you do, then you can develop at within 24, 48, even 72 hours, you can develop a later type of reaction to them. Graft rejections are also these types of type 4 hypersensitivities. So all of these are just examples of when your immune system is doing too much and it's harming your own system. So these are some definitions for you that are on your student learning outcomes, and you can take a look at some of these, and I think these are pretty self-explanatory. When we think about who's affected by allergies, it's obviously a significant number. So most of them are mild, which is the good news, but some of them can be life-threatening. As we said, anaphylactic reactions can be life-threatening. Why they are happening is because of this increased IgE production, which is going to cause a massive release of histamines and other cytokines and other interleukins that are causing the body's tissues to have over-inflammation and just too much of a response to these particular molecules. As far as probability of developing allergies, you can see some of this data here, and that is just FYI. There is this idea that this hygiene hypothesis is this idea that actually we need these microbes in our environment early on in our environments because they train our immune system. So actually you can live in too sterile of an environment, too clean of an environment, but then also you can live in non-hygienic situations. So really there's this happy medium that people should be in. They shouldn't be in too clean of an environment, and certainly it should be clean enough. Breastfeeding has obvious benefits, and this is just another one of those. We understand that babies that are breastfed, they're being introduced to many different species of bacteria through the breast milk, and these microbes, we're just beginning to understand the full importance of them and how they are benefiting those neonates and those infants in later life, things that will follow them throughout their life, so we know how important this can be. Okay, as far as how allergens enter into the body, some are going to, with their different portals of entry for that. So we inhale, we ingest, they can actually be injected, and then just coming in contact, like with the skin, with these delayed hypersensitivities, like contact dermatitis, poison ivy, things like makeup and that kind of thing can cause those types of reactions. So you have, this is all from your textbook, and you can go through some of these. Histamine is a powerful molecule. We know that it constricts the vessels, which is going to help which actually raises blood pressure. But what it also does is it constricts the airways, it constricts the airways, but at the same time it's relaxing the blood vessels, which is going to cause a decrease in blood pressure, and at the same time it is also going to cause those blood capillaries to become leakier, so water from the plasma can move out into the tissue spaces much more readily. Those two things happening at the same time, the blood capillaries dilating and also becoming leaky, is really going to cause fluid to be in those sites and edema to be in those sites. If it is happening systemically, this is going to drop blood pressure really quickly. Because it is constricting the respiratory airways, the bronchi and whatnot, this is going to lead to labored breathing and then even intestinal motility. So all of those things are situations that can happen when there's an overproduction of histamine, which we know eosinophils are going to be containing as well as basophils. So these are some other types of cytokines that can initiate some of these responses, and those are going to be for your information, but I'm sure you got introduced to them in anatomy and physiology, but you can just take a look at some of those. And I had more slides than I realized for this, but okay. Drug allergies are, food allergies and drug allergies are obviously of concern. When we think about any of these types of allergies, some of them can be rapidly devastating to the individual, and again can put them in an anaphylactic type of situation. So you're looking at some of the most common food allergens here. Shellfish is a big one, milk, eggs, peanuts. It's usually because of a fungus that's on the peanuts, but these are some of the ones that are the most common. Drug allergies too, we know we encounter, so there's some patients that you will find that are resistant or are allergic to almost all of the antibiotics that we have available, and so those people are very much are challenges to try to treat appropriately. And I had talked about anaphylactic shock and anaphylaxis and how dangerous this can be, where the blood pressure drops suddenly. And with that also the breathing is going to be so labored. So epinephrine is going to usually be administered immediately, because epinephrine will actually do the opposite of what histamines do. Epinephrine relaxes the respiratory bronchi and at the same time constricts the blood vessels, so it's going to counteract what all of those histamines and other cytokines are doing to the system, and certainly saves lives. Some of the diagnosis for how we diagnose different allergies, there's different things that can be done. This RAS test is actually going to be a blood test that's measuring for very specific antigens and seeing if the person is reactive to those. We also have skin testing. Probably some of you all have had these types of skin testing done before, where it's delineated and they know exactly what they're presenting in these scratches in the skin, and then if there is a reaction, a wheal and flare type of reaction showing, then that means that the person has developed antibodies that in the IgE class that is causing this increased fluid in these sites. So you've got edema, you've got the redness, and the rash that is showing from that. How do we treat? How do we prevent some of these things that can be happening? Well, obviously one of the ways that you could prevent is to first knowing what you're allergic to, but then also having that patient avoid the allergen. That's easier said than done. Some people live in areas where there's no way to really avoid the allergens that they're exposed to, because they're part of their ecosystem. Another thing to do is to actually take medications that can block the action of those lymphocytes, and especially those chemical mediators, those cytokines. So different antihistamines and different medications for allergies, these are some of the modes of action that they are using to try to block those reactions. And then sometimes using injections that really kind of short circuit that allergic reaction. We can also give people allergy shots to try to get them to seroconvert from producing IgE to seroconvert and start producing IgG antibodies, because if they can ever do that, when the antigen is presented to the body, the IgG would absolutely take it out of commission and there would never be a reaction. So corticosteroids, they're inhibiting the activity of these lymphocytes and reducing the IgE. So these are just some of the things. This is FYI for you, but some of the ways that we can block those allergies. Antihistamines we talked about. Theophylline is a very commonly used with caution, but commonly used bronchodilator, so it can reverse those spasms in the respiratory muscles that are controlling the openings of those bronchi and how large those bronchi can actually get. Epinephrine we talked about. So the desensitization, the vaccines, this is what, another type of thing that we can do to help to treat. I hope that makes some sense to you. All right, I wanted to talk about Rh factor and its clinical importance. Rh factor is actually referring to a D antigen that is sometimes found on people's red blood cell membranes. If they have this Rh or D antigen, then a person is considered, their blood type is considered to be positive. So, you have the A and B antigens that you may or may not have inherited as well. That's part of the ABO major blood typing. But this Rh factor is another type of inheritance of an antigen that may or may not be found on those red blood cell membranes. So if a woman has the Rh antigen on her red blood cell membranes, if a woman does, then what will happen is she will never make an antibody against that D antigen that she has. And so she really won't have a problem with that. But when women are Rh factor negative, when they are negative and they become pregnant, if they become pregnant with a baby, a fetus, so I'd say a fetus that is Rh positive, maternal and fetal blood never really mix. But if during that pregnancy, that Rh negative woman ever gets exposed to even one drop of the fetal blood that's Rh positive, that woman's immune system will think of that D antigen as being foreign and being a potential pathogen. So that woman will produce antibodies against the D or Rh factor antigen. She'll produce antibodies against it. Now, usually on the first pregnancy, that's not going to be a problem because that fetus is being delivered. So a drop of blood wouldn't even have usually gotten to the mother's immune system until the actual birthing process. But during the birthing process, with the umbilical cord cut and whatnot, a drop of fetal blood touching that mother's immune system, getting into that mother's immune system through membrane tears, through whatever, that mother's immune system will form antibodies against D. So in subsequent pregnancies, the next second, third, whatever, if that fetus, the subsequent fetuses, have the D antigen, that mother's antibody against D, they can cross the placenta. Mother's antibodies, we usually think of that as being so protective for fetuses, but in this case, this is deadly to a fetus, and this is going to be a huge problem. So hemolytic disease of the newborn and Rh incompatibility is what I've just been talking about. This is why women who are Rh negative are going to get something called RhoGAM. RhoGAM is actually just all this is. RhoGAM is an injection where these antibodies against D are going to seek out any potential Rh antigen and cover them and mask them from the mother's immune system. So these injections are really important. Right now they're given at 20 weeks of gestation and then within 72 hours of delivery. That's typically what's going to happen if a mother is Rh factor negative or D antigen negative. D antigen is the same thing as Rh factor. Okay, so hemolytic disease of the newborn is also known as erythroblastosis fetalis. This is going to cause these antibodies, if the mother has them and they cross the placenta, it is going to cause that fetus's blood to lyse. And as it does that, this fetus is going to be severely anemic, poisons are being put into the system of this fetus. They're going to turn jaundice, bilirubin's going to build up, and this is usually going to end without any medical intervention, and it would be an incredibly high-risk pregnancy. This is typically going to end in a stillbirth or the fetus not making it. So the good news, though, is that with good prenatal care, we know when a mother is Rh negative, and certainly she is going to get the RhoGAM shots at 20 weeks and 72 weeks. So this is important. In your textbook, they talk a little bit about checking the father, and here's and I just put this in here because it's from your textbook. I want to let you know something as far as medicine goes. This is absolutely, a careful history is required, that's for sure. But the father, this is not taken into consideration who the father is, because there's no way to assure that the fetus that's being carried is from the person that the woman may say is the father. You would never take that risk. So in other words, if it is true, though, if a mother's Rh negative and the true father is Rh negative, then the baby can't be Rh positive. That really is true, and that really is true that there is no risk. But you're not going to accept this because you're going to assume if a mother is Rh negative, you're just going to handle the risk that the fetus might be positive by always giving RhoGAM. So I hope that I made that pretty clear and people understood that. All right. So some of these dates that the textbooks give are a little bit different than whatever, but it's usually around the 20th week and usually within hours of delivery. So again, some of these slides are helping you with that, and I hope that some of that actually makes some sense to you. So you have a lot of slides that go through, in this PowerPoint, that go through discussing these hypersensitivities. I do want to touch on the organ transplant and rejection, so transplant rejection situations that are happening. So this is important to know because we do understand that when somebody gets a transplant that is not from their, another part of their own body, like skin transplants can happen, if they're getting a transplant that is from someone else, then there's going to always be this idea that they're going to have to take immunosuppressive drugs. So now the person's immune system is not going to be working up to par. So there's always going to be the risk of them having opportunistic diseases that can be very serious types of diseases. So when we think about organ transplantation and the problems that can occur, it's usually because of cytotoxic T cell action, so those T8 cells or CD8 cells, and we had said how absolutely wicked those cells can be. We do understand that each person has their own major histocompatibility proteins, and these are different class markers that are self-recognition markers that are unique to them. There are a couple of different types of rejections that can happen when you're talking about transplants. There can be the host rejection of the graft. So in this particular case, antibodies get formed against those transplanted tissues, and that's what's contributing to the damage. And it's going to be death to the graft when that happens. But there's also another type, and that's what we tend to think about, but there's another type of problem that can happen, and this is going to be a graft rejection of the host. When we think about graft rejections of the host, this is when tissues like bone marrow that contain quite a bit of populations from the donor into the host, this reaction is going to occur where all of a sudden these cells are now going to start attacking multiple organ systems. Usually it's many organs are affected, and attacking the organs of that host. This is neither of these are good news, but if a host rejects the graft or an organ, then that usually can be taken out, and the person, if they survive that event, can go back on a transplant type of list situation. When this happens, you can imagine this is a devastating kind of consequence. It's really hard to reverse, and it's usually going to happen within these days of getting, because now it's just not the host rejecting that one site that was transplanted, it's the graft rejecting the entire patient, and multiple systems affected in that. So those are two different types of rejections. There are classes of grafts, so an autoimmune self. So this is where a transplant is going to happen from one area of a person's body to another, and as long as that was done correctly with good blood supply, there's usually not too many issues with this. Isografts are interesting because you'd have to have an identical twin, and we know that that's not usually the case. Most people don't have an identical twin, and even identical twins sometimes don't agree to have the grafting, so this is pretty rare. Allografts are actually exchanges between different individuals in the same species. So these are definitely the most common types of grafts, and we have now a lot of living donors that can happen with organs like kidney donation from living donors, even liver, and so this is really this is happening quite frequently now. Xenografts are going to be when the tissue exchange is of a different species. So different animals are used for like heart valves and whatnot. So these are just some of the examples of these different types of grafts. So I talked about sources of organs. They can be live donors. These are some of the situations for that. Cadavers can be used, heart, kidney, cornea, fetal tissue from stem cells. So these are just some of the situations for that. All right. So inappropriate response to your own self, this autoimmunity. Auto meaning self, immune disease. So it's important that people understand that an autoimmune disease is not contagious. It is not a virus, bacteria, it's not any of those things. It's when your immune system has made a response that the molecules that they've made are now targeting your own system and your own organs. So there are many different types of autoimmune diseases. Autoimmune diseases are definitely on the rise, and they can occur because of a cross-reactivity to something that was foreign that you had. So they can occur sometimes because you have maybe a mild encounter with a virus or whatever, and your immune system responded appropriately. But the products that were made when that response happened started to cross-react with some of your own self-antigens. So some examples of autoimmune diseases: systemic lupus, and you see what type of hypersensitivity that is. I am not going to ask you to match to which type. I just want you to understand that these are going to be because of antibodies or cellular responses that are a problem. So now they are going to have organ damage because of them. Rheumatoid arthritis, ankylosing spondylitis. This is going to be when bones are these joints are so degraded that the bones are forming spurs, and the joint is completely completely useless and incredibly painful at these particular sites, and the damage a lot of times is going to be irreversible. So Graves' disease, antibodies against that actually are very similar to what the thyroid stimulating hormone receptors receive, so they interfere with those receptors. Myasthenia gravis is a very, again, some of these are pretty common. Myasthenia gravis are going to be these antibodies that are against those acetylcholine receptors on muscles. So type 1 diabetes, we know, is going to be that you are attacking your own beta islet cells of the pancreas. Multiple sclerosis is a situation where those glial cells, those oligodendrocyte glial cells in the central nervous system that provide myelin for us, the myelin sheathing that are on the axons that help to speed the signals that are sent in our central nervous system, this myelin is going to be attacked, and it's going to affect the central nervous system. So again, kind of a devastating situations here. There are many autoimmune diseases, but this is just a list of some of the ones that I'm pretty sure that you guys have probably heard of. Hashimoto's thyroiditis, that is, instead of a hyper secretion of the thyroid gland, that's a hypo secretion of the thyroid gland, again because of antibodies against the thyroid. Sjogren's, and just many others. Okay, so again, we are thinking that we do understand that many of these autoimmune diseases, they really do affect usually more women than men, but we don't think of them truly as being sex-linked kind of disorders. They're really disorders. When we think about these disorders, they can be seen in men, but it does seem like most of them are in women. Tends to happen, and most of them, if you look, the onset is between 20 and 40 years of age. So those are just some of the things that we think about with them. Psoriasis is another autoimmune disease that can happen. So, and that can affect the skin as well as affecting the joints. So there are many that can actually affect the joints. This is that butterfly rash of lupus, and this is the ankylosing type of spondylitis, the ankylosing rheumatoid arthritis situation. So you've got some slides that go over some of these that you can look at of these examples. Again, pictures that show you how they interfere, these antibodies interfere with the receptors on the target cells. So if acetylcholine can't get in this, then there's paralysis of the muscle. Myasthenia gravis can be just like all of these autoimmune diseases. You'll see some people who have mild symptoms and they go in and out of remission, so sometimes have no symptoms at all, and that's the way their disease will be. Others will have a course where they have lots of times that they are out of remission and they're having serious kind of consequences, and then sometimes they are going to be very serious and no remission ever happens, and they can actually lead to death in a pretty quick kind of hurry. So it just depends on the individual. It depends on their immune response, and so it's really like there's no two that are exactly alike. Again, lots of slides that I've presented you with these that you can take a look at. As far as immunodeficiency diseases and not having enough, what we just talked about was all too much of a response from our immune system. All of those 4 classes we just talked about, that's too much of a response. But there's sometimes a problem because there's not enough of a response of the immune system. So hypersensitivities of the immune system can either be primary, which means that you're born with them, congenital, you're born with them, and it's usually because of lack of certain information that a problem that happened, that your parents either had information that was passed on to you, or mutations that can actually happen. So you are born with these. And then there's some secondary immunodeficiencies, which means that you acquire them after birth. And they can be either from natural things or from artificial agents like viruses. HIV, human immunodeficiency virus, attacks the CD4 cells, and because it does, and as well as B lymphocytes, but it attacks those CD4 cells, which we know all specific immunity hinges on. So this is why this is so devastating to our immune system, and this would be an example of a secondary immunodeficiency. So here you've got some examples of primary immunodeficiencies where you are lacking sometimes you're lacking the ability to make certain immunoglobulins. Sometimes you're lacking complement proteins. Sometimes it's that the thymus gland is not working the way that it's supposed to. So those T lymphocytes cannot mature the way that they're supposed to. And again, here's some examples of secondary immune deficiencies that are acquired. Natural causes, or even from agents that can can hurt the immune system. Steroids, you know, our body produces natural steroids, as in cortisol. We produce a certain amount every day, but taking them synthetically, like with prednisone or other anabolic steroids for long periods of time, definitely suppresses the immune system. Not having a spleen, which is one of our first, places where foreign antigens are discovered, that makes you immunocompromised, and then certain other conditions that can happen. So the next section here is actually looking at ways that we diagnose infectious diseases. So we talked about the idea that infectious diseases can be so rapidly devastating. A nice healthy person in the prime of their life can encounter some of these infectious diseases, and within hours, if the right diagnosis isn't obtained, then within hours, if the right treatment wasn't obtained because of that, then you're going to lose this patient. So how we go about diagnosing microbial diseases, there's three different major ways that we think about: the phenotypic, immunologic, and genotypic. So these are the things that we use, and we use all of these now. Predominantly still, most of them are going to be looking at these first two, but as costs come down for these immunologic and genotypic, as costs are coming down for these, we're going to start to rely more and more in the future on these, and we'll talk about why that would be in this next little section. So when we think about phenotypic, it means that you are taking your specimen, culturing your specimen out, also doing gram stains and other types of stains, using a microscope and actually looking. We know phenotype means what can you see, what's being expressed, right? Not just at a microscopic level, but also a macroscopic level. And so you're absolutely using those types of things and trying to figure out what you've got as quickly as possible. The problem with this comes when you're having to grow organisms out in a lab on agar dishes and, having to manipulate them this way. This can take hours. Genotypic is when you're actually going to analyze DNA or RNA from the specimen, and if that DNA or RNA is from a very specific organism is found in the specimen, then there's your answer. This also, some of the techniques, like this particular technique, can take a little bit of time. Not as much time as it used to take, because now we have PCR testing, polymerase chain reaction testing, where we can take a very small sample and amplify the DNA or RNA that's there after we've prepared the specimen, and after a few replications of our unknown, we can test it to see if a potential pathogen is there or not. So that's helped with the timeline. PCR testing has helped with that. We also know that RNA, ribosomal RNA in bacteria is very different than in eukaryotic organisms. So that understanding has also helped us a little bit too. These electrophoresis plates and IDs here with these genotypes are great, but we also are getting more and more techniques that are probes that can be almost instantaneous. They're expensive though, but anyway, this is the future right here. Immunologic, and this is what I need for you all to understand with immunologic serology testing. When we think about serology testing, and there'll be a slide or two here, but anyway, when we think about serology testing, this is going to be where we're looking either directly for the antigen that might be present. So we're looking for the antigen from our specimen, and that means the bad guy, if you will, the foreign antigen. So we're looking directly for that, and this can be done in minutes, really, when we're doing immunological surveys. So in serology, we can do direct tests where we're looking for the foreign antigen, the bad guy, by using known monoclonal antibodies. And if there's a reaction with our specimen with those known antibodies, well, we know antibodies are specific, so there wouldn't have been a reaction unless that bad guy was there, that antigen was there. There's also something called an indirect serology test. In an indirect serology test, you're not looking for the bad guy. You're using the patient's own serum, the patient's own fluids, a specimen from the patient, and you're looking for antibodies to a particular bad guy. As we know from our study of the immune system, a person cannot make antibodies against something they haven't encountered. Their immune system makes antibodies specifically against foreign antigens that they've encountered. So in an indirect serology test, what would be used, and again, these can both be done usually within minutes of collecting a specimen. In an indirect serology test, you're going to be looking to see if that patient is forming antibodies or has formed antibodies against a particular antigen. And getting titers to those can be absolutely diagnostic. So, diagnosing disease, we've already said that you have to know how to collect the specimen properly, how to handle it properly. If there's going to be any storage time or downtime before it can be sent to an appropriate lab facility, you've got to know how to do that. And then certainly once it's there, the laboratory has to know how to culture it. So all of these are going to be important things to know as specimens are, if whoever's collecting sputum, throat, wound, specimens, stool specimens, whatever cerebrospinal fluid, urine, any of these specimens, you've got to know how to collect the specimen and what specimen is going to be the specimen that would be needed to get whatever potential pathogen you have that you think that you're dealing with. So these are some of the different types of urine samples. Not all urine samples are created equal. As far as microbiology goes, what the best specimen that we can get, one of the best specimens we can get is a clean catch midstream specimen. If it's actually done correctly, then that is a great specimen. Sometimes in and out catheters are actually done, but if that midstream clean catch is done like it's supposed to be done, then it's as good as an in and out catheter specimen. So anyway, just some things to be thinking about with that. Skin, we can't sterilize the skin. It's impossible to sterilize the skin, but what you can do is certainly, and depending on the degree you go to try to do this is going to depend on what kind of specimen you're getting. Like if you're just drawing blood or whatnot, you don't have to go to as much trouble as if you were trying to get blood cultures. If you're trying to get blood cultures or cerebrospinal fluid, you really do not want to be introducing microbes into these areas. So obviously all of your equipment's sterile, and antisepsis of the puncture site is really important. You've got to try to reduce and remove as many of these organisms as you can. There's no way to get a complete sterility of the skin, though, is there? So labeling, obviously this is just showing you for collection different techniques that can be used, different equipment that you would use for each one of these, and then also sending in and being very careful about how you label the specimen, when it was collected, how it was collected, what might be suspected. Those types of things are going to be really important. So phenotypic methods we talked about, we're going to be doing different staining, gram staining, acid-acid staining. Just looking at the specimen itself, you can actually look at a specimen sometimes and tell, again, this wouldn't be macroscopic, but looking at a specimen and seeing if there's pus there. Pus tells you that the body's actually been trying to find that, so to fight that, so there is definitely a problem there. We've already talked a little bit about this media, the different media that's used. We have specialized media that is going to help with just recovering and those particular pathogens. We have selective media that can select out for like gram positives versus gram negatives. We have selective media that can select out for gram negatives and inhibit gram positives. We have media that can be differential, so we can look at the media and tell if something is fermenting a particular sugar that we know we have in that medium, and if it is, it's going to change the color of the media. So right away we'll know that, you know, we're headed toward our path to get that differential diagnosis. If something is in pure culture, A pure culture means that nothing else is growing but one thing. So usually if something is in pure culture, that is a pathogen. There's your sign on that one. There is a pathogen at that particular site. Once we get pure cultures and have selected out, we know something is a pathogen. I want to talk to you for a second about understanding if it's a pathogen or not. If there's a pure culture on the original specimen that's sent, nothing else is growing except this one thing from that specimen that you inoculated, then that usually tells you that whatever's growing there, even if we know it can be part of normal flora, in this particular case, since nothing else was growing but that, then it's become probably an opportunistic pathogen. There's sometimes other pure cultures that can happen, though, where we have what are called true pathogens. Let me explain the difference between a true pathogen and an opportunistic pathogen. We all know that Staphylococcus aureus is on our skin, it's in our mouth, it's up our noses, it's part of our normal flora. It doesn't usually cause most of us any problem. It's part of our normal flora. Now, if a patient becomes compromised, lots of things can cause compromise. Surgery, illness, taking chemotherapeutics, all kinds of things can disrupt the normal flora. Then Staph aureus can take the opportunity to cause disease. So if we see it in a pure culture, even though we know it can be on the skin, or if we see it predominating in cultures on the skin, then we know it's become an opportunistic pathogen. It was that patient's Staphylococcus aureus that was part of their normal flora, and it took the opportunity to cause disease. But there are some microbes that should never ever be present. They can't be present even though we know there's lots of microbes on and in us. These should never be present. If we ever get them out in culture, they are a pathogen. They are true pathogens. Here's an example: Neisseria gonorrhea. That's a bacterium that causes gonorrhea. If it's ever there, it is a pathogen. It's not part of normal flora. It's not an opportunistic pathogen. It is a true pathogen. It should never, ever be present. If it is present, it's a pathogen and needs to be treated. So how do we identify them? When we now are dealing, with what we think are either opportunistic pathogens or true pathogens, how do we identify them? We have to get them in pure culture, and then we send them through a series of biochemical testing. This is all of these little wells. These are little mini wells that have a substrate, and then you rehydrate that substrate with your unknown microbe, and you put it against all of these tests. From here back are all sugars. The only sugar this particular unknown is fermenting is glucose, because there's been a color change. I can see because of the pH change in fermenting glucose. There was a color change for me to see this. These would all be considered negative. This one's considered positive. Bose Proskauer, gelatin, if it has gelatinase, this would have dissolved this, so that's negative. This is negative. So anyway, these are all just abbreviations for tests that are done here. And if they get a positive determination, they're given a number. So you'll see these first three, that this one was the only one that gave a positive number. So this is the first number in this series. This it gets a number. This number is considered its analytical profile index number. That's what this number correlates with. And it means in an analytical profile index number, we've done a series of biochemical testing. We know which number they're each associated with. And this unknown that we started with, because of its number, is now not an unknown. This is Wartziella tardive. This used to be well, it doesn't matter what it used to be called, but anyway, it had a different name. It was Escherichia. But this gives us this ID. So we take our pure culture of our unknown, we make a suspension. It takes about 5 seconds, makes a suspension in a sterile solvent, and then we inoculate these little mini wells with a pipette incubate them for a specified period of time, read through colorimetric methodology, just looking at the colors, whether they're positive or negative, come up with our number, and it gives us the ID. Biometric testing. The beauty of that is that it's, good. But the problem is that it usually takes a day or two to get the unknown isolated in pure culture. Then after you do this takes another day to incubate for your reading. So this is going to take some time, isn't it, getting to this ID? So that becomes the problem with that. These are other, ways we said we get to our differential diagnosis by doing Gram stains, then doing some basic testing. That's pretty basic. Like that one only takes a few seconds on a slide to do a catalase test. Oxidase only takes a few seconds as well. And looking at whether they ferment or sugar in the agar can also help us with that. So anyway, these are some of the ways that we phenotypically identify microorganisms. So we can also do antibiotic and sensitivity testing. So antibiograms are nice in doing that because that can lead us to the diagnosis. All right. Okay, so this is talking about quantification and understanding that quantification plays a huge role in identifying whether something's a pathogen or not. If you have E. coli, which we know to be a potential pathogen to cause urinary tract infections, it's the most common. Escherichia coli is the most common bacteria to cause urinary tract infections of women, and we know that. But if you get a urine specimen that has very few colonies of E. coli, but a lot of other colonies of mixed flora, then that E. coli just came along for the ride. It might not be a pathogen at all. But if you had a pure culture of this, then we know that is what's causing the urinary tract infection. But if you have a single colony, just one, of Mycobacterium tuberculosis, that is always a disease. So that is what we call a true pathogen, just like I was talking to you about Neisseria gonorrhea. There should never be that in your genital specimen, whatever you've gotten. I had talked to you about PCR testing, and we know what that stands for. We know that this is a methodology that amplifies our nucleic acids. And as we amplify those nucleic acids, then we're able to test them and put them through a series of tests, either through gel electrophoresis or other types of probing tests, and we can identify specifically what is present through these genetic testing. The problem that we still encounter a little bit is just the problem that it's still expensive, and so this is why we're still doing more of the phenotypic testing than anything else. I have also talked to you about serology. So testing serum. Serum is actually plasma that is lacking the blood clotting factors, but testing body fluid serum and seeing whether directly we're looking for in direct testing we're looking for antigens, and in indirect serology test we are looking for antibodies. These really have a high degree of specificity, so we can feel very confident with these results and know that these results are going to help us with that potential definitive diagnosis. Titers are when you're actually looking at how many antibodies are actually present in the sample, so it's literally a quantification. Again, this can be indicative of your disease and your diagnosis. So all of these tests, these are just different examples of immunofluorescent testing. So there's some different examples that are shown in your book. Fluorescent testing for, let's say, syphilis. Syphilis is caused from a bacterium. The bacterium is Treponema pallidum. It is a spirochete, and you can see it here. And it has been tagged with these fluorescein dyes, so they are lighting up so that you can actually see them. And how nice is that, right? Indirect testing, though, indirect testing would be looking to see if someone has the antibodies in their serum. Again, a person would not have antibodies unless they had been exposed to the actual antigen. So that is just as diagnostic. An indirect positive test is just as diagnostic as a direct test. So again, there are lots of different techniques for as far as these indirect and direct serology testing goes. There are a lot of different methodologies for doing that, those particular testing, and they're very, very helpful. I did want to let you know that the way in this country we screen for tuberculosis is by doing an indirect test for Mycobacterium tuberculosis. So, you know, it's that little skin test that you do, and you look after 48 to 72 hours, you look to see if a person reacts to that. If they do, it means that they've made the antibodies against that particular bacterium, which is Mycobacterium tuberculosis is the name, the genus and species of that. If they've made an antibody, it means that their immune system has encountered that antigen. So this has to be addressed, and this person is going to go through a series of tests after that. If this is positive, they're going to go through a lung x-ray, and even if the lung x-ray is negative, you can't take a chance, so the person is going to have prophylactic treatment that usually lasts a minimum of 6 months. And you all had looked at that, the testing, the treatment for that, and you know that it can be pretty serious. The isoniazid and rifampin can have liver damage, so the person is going to have routine testing to make sure that you know, they're handling that medication okay. And again, it's prolonged treatment because it is that serious of a disease. Breakthrough methodologies. You know, we know these can be the most serious diseases, but getting to the diagnosis can be so frustrating because it can take so long for the test to come back. So taking 18 hours or more, that patient could have died 3 times in that amount of time before you can actually get to that. So I'm not being overly dramatic either. That actually can happen. Now the good news is most of them aren't that serious, and most of them you are going to be able to, even if you have to put the person on a broad spectrum antibiotic, you're going to be able to do that. And then once you get your definitive diagnosis back, you'll be able to narrow that chemotherapeutic down so that it has less consequences with a higher therapeutic index for the patient. So there really are some breakthrough technologies that are actually happening now. We have microarrays, which are really nice because these particular, it's a one test situation that has a lot of different tagged potential organisms that they're going to be looking for, so that one test can be done and it's going to have a large differential diagnosis associated with it. Again, there's nucleic acid sequencing that can be done, done pretty quickly, especially now with the probes and the PCR, but expense is holding some of that back. And then mass spectrometry, which is going to be looking for products that we know certain bacteria produce that are only produced specifically by those particular pathogens, and we can, if we identify these products in the sample that we get, then that's an answer. And so mass spec's been around for a long time, but it's being utilized in more cost-effective ways now than it has been before. And so these are some of the things that we are being able to use. And then imaging. We have more and more imaging now that we can do that's helping, and we can see these 3D slices and analysis that help to identify especially localized infections in deep tissues that are helping to get to the diagnosis. So those are all breakthrough kind of technologies that are happening, continuing to happen, and new things going on with them. Microarrays, nucleic acid sequencing, mass spectrometry, and also imaging. Okay, after this section, we get to start with etiologies of disease, looking at organ system by organ system, naming organisms, knowing what those organisms, their genus, their species, and what specific diseases they're associated with. So we're ready to go.